are introducing our next speaker.
Yes.
For our next,
I think I'll just follow in English. Huh?
That's good.
Yeah.
You can do that, improvising.
So we're very honored for our next speaker as well, which is Professor Pim Kuipers. He's a professor in clinical psychology at the Free University of Amsterdam. And the reason why we invited him is because in many instances there is this automatic thought that precision medicine is always about pills and medication and genetic and genomics. But I think Pim Kuipers is going to show us that nothing is less true, because also for more psychological treatments and therapies, there is very much to gain to think from the framework from individualization and treatment predictions. He has an extreme track record, really extreme, in terms of executing randomized controlled trials, meta-analyses, and also prevention from this framework of psychological therapy. So we really look forward to what you're going to tell us about this aspect of precision medicine.
Thank you very much for the kind introduction and for the invitation to speak here.
Yes.
Fascinating that this can be done all online and virtual. That's great. Yeah. But you only gave me 10 minutes to speak, so I will go through my slides quickly. And I will do three things. I will first talk about what's better, psychotherapy, farmacotherapy, or that combination in the treatment of adult depression. And then I will talk about what we call individual patient data meta-analysis, because they allow us to see in much more detail who benefits from which treatment. So first, psychotherapy, pharmacotherapy, and their combined treatment. So we have this huge database, which has now more than 750 randomized trials on psychological treatments of depression, and we update that every year. And I could talk 2 days about that, because we have done so many meta-analyses and explored so many things, but I don't have the time for that. That's also interesting, because what you see is that the number of trials grows every year exponentially. And that makes this the best studied field of psychological treatments. And it also allows us to look at all these different comparisons between therapies, with control conditions, which types, which format, but also the combination of pharmacotherapy. And that's what I will focus on today. Well, this, if you want to know more about our meta-analysis, this one was published. This is a conventional meta-analysis published this year in JAMA Psychiatry, in which we found that the effects of psychological treatments in depression are significantly smaller in children, but also in adolescents compared to adults. And what I also find pretty shocking there was that there's hardly any research in Europe. All the research is in the United States in children and adolescents. But that's not the topic of today. We published earlier this year, a network meta-analysis of all studies comparing psychotherapy, pharmacotherapy, and their combination. And that's the largest meta-analysis up to now of these studies. So we had, this is the network, not very interesting, but we had 101 trials with almost 12,000 patients. What we found, we knew most of the things, so the combination is much better than either psychotherapy or pharmacotherapy alone. And psychotherapy and pharmacotherapy have the comparable effects at the short term. But as I said, the combination is significantly better. And that's also true for chronic and treatment-resistant depression, for people with severe depression. And here we also found that the long-term outcomes were comparable. Severe depression is important because I know from routine practice that many psychiatrists are inclined to say to severe patients that they first have to start with medication because they cannot do psychotherapy, but they often don't consult a psychotherapist for that. And I do think that's, in many cases, very important. So the longer term effects, I will be very brief about that. So combined treatment is better, but if you compare psychotherapy with pharmacotherapy, probably psychotherapy has longer lasting effects than pharmacotherapy. So if you stop during 1 year follow-up with pharmacotherapy, then the effects of one-time psychotherapy are better. Yeah, as I said, I don't have time to go into that. So I will switch to the other thing I want to talk about, and that's much more about the subject of today. That's these individual patient data meta-analysis. So what we do is, from our database, we select studies comparing with one comparisons. And then we ask the authors of these studies to give us the primary data. And so we get these huge data sets. One of these data sets is one in which we compare CBT with antidepressive medication and pill placebo. And the nice thing is, because you have these individual data, you can look which characteristics of patients predict outcome. We found no difference between men and women. We found no association between baseline severity and outcome, meaning that also in severe depression, psychotherapy, CBT and pharmacotherapy have comparable effects. And we found no association between other socio-demographic characteristics and outcome. But surprisingly, we also did not find a difference between pharmacotherapy and CBT in melancholic and atypical depression. The problem with these individual patient data meta-analysis is that we do not have so many comparators, because all these studies use different characteristics. But we're working now in all kinds of studies to increase the number of characteristics that you can examine as moderator. And so I will show you one individual patient data network meta-analysis, which we conducted 2 years ago with Toshi Furukawa in Japan and his group. It's about CBESP, so it's psychotherapy for chronic depression. And there we had 3 studies, but large studies. So, and these 3 studies had very comparable moderators, predictors of outcome. And there we did find several significant predictors. And so what we made, you can find it on the website there. I don't know if you can see that, but in the left column, you see all these patient characteristics: baseline severity, baseline anxiety, age, and a few other characteristics of patients when they start treatment. And at the right, you see what happens if people get CBESP, the combination of CBESP and medication, or only medication. And here you see an average patient, average severity, low anxiety. This is a website, so you can just go there and fill this all in for an individual patient you're treating. And I made screenshots here just to show how it works. And in the next slide, you see the same patient, same characteristics, but also that the baseline anxiety was much larger. And there, for this patient, the combination is clearly better. And CBESP only is clearly less good than the combination. And pharmacotherapy is somewhere in between. And this type of analysis, we're working now on several individual patient data meta-analysis, making comparable prediction sheets. And so I hope in a couple of years that when we get more and more of these IPD meta-analysis, that we can give more of these individual predicting outcomes. So I come to my conclusion. So I do want to say something about this paper in JAMA, which I wrote 2 years ago. Not everybody was happy with that, because I said there in an editorial that the effects of treatments for depression are actually not that good. Many people get better without treatment. So you think as a clinician that people get better because of treatment. But the majority of people get better spontaneously without treatment. And you don't see that because you're treating them. So a lot of people recover spontaneously. At the other side of the spectrum, you have a lot of people who don't respond to anything, whatever you offer. And so our treatments work somewhere in the middle. And that's not a broad area of possibilities you have there. So I think it's a very important reason to start developing personalized treatments. And we don't have many of them, not in the field of pharmacotherapy and not in the field of psychotherapy. And we're already working on it for quite some time. So that is a big challenge. So I come to my conclusions. I think both psychotherapy and pharmacotherapy are effective, but the combination clearly is better. And I failed to say that in my presentation, but acceptability, which we defined as study dropout for any reason, is better for combined, but also for psychotherapy compared to pharmacotherapy alone, which is, I think, an important issue. And then I think individual patient data meta-analysis, getting the same outcome measures, getting the same predictor variables in all randomized trials we are doing. That's a challenge for the next few years. If only 10% of these 750 trials on psychotherapy for depression would have used the same outcome measure, the same predictors, the same moderators, we would have personalized treatments now. And that's really a waste of money and a waste of resources. So I didn't do these meta-analyses alone, obviously. So these are all the co-authors of these meta-analyses.
Yes.
And I thank you for your attention.
Great,
Yes.
thank you.